Hey, how are you doing, Tess?
Sorry, I was muted. Good, how are you?
Good. You say I was having a heart attack. It said, "We'll talk to you at 8 a.m. on Wednesday." I was like, "Oh no, that's not the right time." Good. Good to see you.
Yeah, I this is my first CTC moderation, so please let me know if there's anything in the middle that like I'm not doing that you need me to say or something, just let me know.
No,
Um
it's all good.
awesome. I the way that I feel like this will my like gauge of it is that I have a list of the survey questions that people filled out.
Okay.
Um, is it best for you if I just read those one at a time and if people ask questions in the chat that seem like relevant, then we can do those before we move on to the next one?
Yeah, good question. I love it. Let's do a hybrid. Let's do. I would love your help with moderating
The
the
chat.
chat. That's great. Although I can usually do that myself too.
Okay.
I have a few things. I like the questions are great. I sequence them in a certain way.
Oh, cool. If you
So
got them, you have that link.
I've got all those questions. There's not that many. They're good, really, really good. No,
Yeah.
I thought what I might do is I'll just start the conversation, and then if I'm missing something or something pops up while I'm talking, interrupt me anytime.
Okay.
Totally good.
Cool. That sounds great. Um, I think I will probably have all of the uh, I'll just let everyone into the waiting room and then I will probably mute myself and then that way it'll just be you or I'll introduce you, let
Okay,
everybody in, introduce you, and then I'll mute myself and I'll just unmute if there's a question in the chat.
got it. That sounds great.
Does Javelle
Thanks.
usually join us for these or
Can't recall. I haven't done one in a while. I'm
okay.
not sure if he's in on these, but I'm glad we're doing your first one here today. That's fun.
I know. It'll be a good experience. Let me have everyone come in.
Sure.
We have teaching conference at 12:30, so I'm gonna be all right. Hello, everybody. Looks like we've got a good crowd in here. I'm trying to get everyone admitted from our waiting room. But this is our first core teaching conference of the year, and these happen on Monday afternoons. Different sites moderate them, but we are going to host the first one here from UW. So we're super excited. I feel like we probably have people from all over the place joining. Feel free to turn your videos on if you want. If you're in the midst of team rooms and have lots of stuff going on, we totally get it, but we always love to see faces. Today, we have an amazing session to start us off with the incredible Dr. Paul Pottinger, who is going to be answering all of your burning ID questions today. So some of you guys sent some stuff in through the survey that we sent around earlier. That's amazing. He has those questions. We will get through as many of them as we can. And then we also really encourage you guys as we're talking and as you're thinking of things, please, please, please put some questions in our chat. We will, I'll be helping Dr. Pottinger moderate that to make sure we get to as many things as we can through the hour. So with that, just a quick intro for Dr. Pottinger, because I realize not all of you guys probably know him as well as some of us, but you've probably at this point gone through some of your orientation and heard some of his talks, some of his work, but he is the director of our infectious disease program and tropical medicine clinic at UW. He also works as a professor in our allergy and infectious disease department. One of the things he is most well known to us for is his antimicrobial stewardship program that he does a lot of work for here at UW, and he does a lot of work with the tropical medicine group here as well. He's won all kinds of teaching awards, also is very near and dear to our hearts in the teaching space, both formally and informally, and we're super excited that he'll join us for an hour. So with that, I will turn it over to Dr. Pottinger and let him take it away.
Okay, thanks, Tess. Hey, how is my audio for you guys? I got a thumbs up. Nice. Well, it's so nice to see all of you, some of you. Thanks for coming on. It's great. Am I correct? Do we have some new R1? Some of the new interns are here. I'm so stoked. I was supposed to teach you guys, I guess I did in a recorded lecture, but it's such a bummer that I couldn't meet with you the other day for Patient Safety Day. But this is me. This is what I look like when I'm not on a pre recorded thing. I am working today from my wife's office in the basement of our house. It's good. It's about 75 degrees. But for those who have just moved to Seattle from other parts of the country, welcome to our burnt hellscape of climate change. It's not usually like this, but we're glad to have you here. It will get cooler, I promise. And glad to talk to you about this topic, which is so fun: skin, soft tissue, and bone. Basically everything except the guts. Internal medicine always lumps everything together unless it's one of the vital organs. So I'm sorry about that. It's a lot to cover. What we had talked about doing, and I'm glad Tess is supportive of this, instead of just a death march by PowerPoint, I wanted to have a conversation. And it's not that PowerPoint's bad, it's just I'm doing 10 of those this week. I just couldn't face it, and I figured this would be more fun for you as well. So I know we have some questions that came in through the survey. We'll get through all those for sure. Definitely time for other questions too. I want this to be interactive. I know it's hard for some of you who may not even have microphones in your workrooms and such, but please do shout out verbally or in the chat box, and Tess is going to help me keep track of those. I want to keep it interactive and fresh. The questions that I got are excellent. They're all exactly the same things that I would have built into a usual PowerPoint. So as usual, you guys are all over it. And I know that we have people at different levels. We have some students, we have some new residents, we have some senior residents. So I'll try to offer something for everybody. And I would also love to get your input. If I say something that doesn't sound right, I may be off base. So you tell me what your real life experience is treating these conditions. So what I thought we'd do is start with the skin and soft tissue, then the bone, and then we'll wrap it up with the diabetic foot because it's a bit of both of those. And it's sort of our biggest, most painful process that we deal with. When it comes to the skin and soft tissue side of things, we do break down skin infections into two broad groups. Is anybody willing to tell me what groups they're thinking about? Maria Corcoran, that does not look like you, but I'm glad to know that I'm on your account. That's good. Good to see you. Skin and soft tissue infections. What's the big branch point that we're thinking about as internists when it comes to SSTI? Monica, nice. Thank you. Good to see you. Someone's calling you from the emergency department. I'm admitting a skin and soft tissue infection to you on medicine. You have this mental model, and you have a whole bunch of questions. The ER never gives you what you need, so you have a lot of questions. But one of the first questions you'd have is what bucket to put that skin and soft tissue into, right? And that's purulent or non-purulent. That's what I'm looking for. Is there pus or not? We never say pussy. You can't write that word in the chart. Purulent. Is there pus or not involved in the clinical assessment? That's key because in the non-purulent world, most of that will be what we call cellulitis. There's different subflavors of cellulitis, and the way we describe it in the United States is different from the way our colleagues in Europe will use the term erysipelas, for example. But is it cellulitis or is it abscess? Is it non-purulent or purulent? So why do we care? Let's say I'm giving you a case that is non-purulent. The emergency department calls. I have a patient in their 60s. They have a red leg, and I think it's cellulitis. I'd like to admit to internal medicine. What are the other questions that you'll have during that admission process as you prepare to go down and see the patient? Yeah, Aaron, thanks. What are the vital signs? Is this patient stable or not? Right? Because you want to know, is this person going to the ICU? Do they need pressors? It's all about sepsis. And is the cellulitis a source of sepsis or not? There's always the backstory in your mind, which is that really why they're even here? I have admitted patients for cellulitis who have actually been having an MI. or a CVA. So sometimes the red leg is a red herring, and you don't want to be seduced into focusing just on that extremity. We do a holistic assessment, and that's always true, especially in internal medicine, where so many of our patients are older, by definition, older than me, right? So older patients who are more comorbid, who have more issues going on medically. So we always have to think about this. But yes, you need to understand, is a patient stable or not? In the case at hand, let's say that this patient does seem to be stable, they have fever and a little bit of tachycardia, but their blood pressure is okay. You're thinking about other comorbidities, right? What is it about this patient that put them at risk for getting cellulitis, if it even is cellulitis? By the way, are there other things that could give a tender, inflamed leg? If the patient has Caucasian skin, we usually call it a red leg. Not all skin gets red, by the way, so that's a misnomer. Yeah, concern. Thanks, Benjamin. Concern for gout, concern for thrombosis. Monica says, what if there's a DVT that's involved? Anything that's going to interrupt the normal vascular and lymphatic flow to that leg. The acuity is key, right? You need to understand whether this is chronic or fresh. If it's a very acute issue, that will take you down one pathway. If it's a chronic issue, it may be something less urgent, etc. I like the idea from Aaron about rashes. What if it's just eczema? There's right, the itch that rashes. There's so many things in dermatology that can give a red extremity, a drug reaction as well. So it comes down to your physical exam. And I'm not a dermatologist. I am not nearly smart enough to do derm, but I love derm. I think it's so cool when you can actually see the organ involved. I'm so envious that they get to look at their organ. I think about the kidneys and the liver. I never see them. Never see them. Unless it's trauma or a transplant, I go into the OR. I just have this imaginary world. But the dermatologist gets to see everything that they are working on. So in the exam, this is really key. Those key features, what are you looking for on examination, please? That would help you decide whether you're in the right pathway or not. Because they're trying to sell you on cellulitis. You are an internist. You have a healthy skepticism. What else are you concerned about? And what will you look for on your exam? Yeah, Aaron, thanks. So what about wheals? Again, thinking this issue of could there be an allergic reaction? Is there a wheal and flare? How firm is it versus squishy and fluctuant, as Monica says? And the warmth. I like to palpate with the back of my hand for a variety of reasons. I find that to be better than the front. I just have sort of hot palms to start with, but the back of my hand tends to run cool. So that gives me a better way to determine whether something's going on. All of these are excellent, and it goes without saying, but I'm going to say it anyway. You're looking at the other side as well. So it's all about symmetry. All of derm is visual, and it's about that symmetrical process. So is there such a thing as bilateral cellulitis? For the record, yes, it exists. I have treated it, and even though you'll read in textbook that it is not a thing, and it is usually not a thing, on occasion you can be wrong. But typically if someone's coming in with a symmetrical pattern of bilateral lower extremity erythema, warmth, induration, tenderness. This could be a vascular issue, right, related to chronic venous stasis, for example. Arterial insufficiency can also do this. Just chronic lymphedema, someone who's been living with congestive heart failure, right-sided failure, for quite some time. They may end up with chronic changes, and that may be all that you're dealing with. So it's hard to tell. The first thing I'm looking for is it unilateral or bilateral? And if it is unilateral, now, okay, I'll buy that it could be cellulitis. If it's bilateral, I'm deeply skeptical, although that patient may need to have antibiotics. Often, usually, they would not. So all of that's excellent. And then again, as you mentioned here, Monica, looking for fluctuants, you're looking for pus. And that particular thing that you're looking for, is there a hair follicle-based issue? If there are follicles that are there, this was sold to you as a non-purulent cellulitis. Really look at the patient. Sometimes the pus may be very subtle, may be very small. It may be based on hair follicles as what looks like a whole field of pimples or hair follicle infections. I would put that person really more into the purulent side of things, and that has implications for how we'll treat them as well. But looking carefully for any signs of pus, the ultimate concern that you would have in a non-purulent cellulitis is a very advanced case. Someone who is not just having cellulitis, but a necrotizing soft tissue infection. Technically speaking, NSTI, necrotizing soft tissue infection, the neck fash, technically speaking, that is non-purulent. This sometimes gets confusing. If there were pus, you wouldn't have NSTI because you'd have pus fighting off the infection. So this is a point of confusion. Remember, not all non-purulent infection is benign. It can be a real emergency. And getting back to the first question that you asked, is this patient stable or not? If they are not, and you have concern for sepsis, now I'm really heightening my concern for the possibility of a neck fash. The approach is different. Cellulitis is treated medically and with some conservative measures we'll talk about in a moment. NSTI requires fasciotomy, debridement, and often amputation in order to save the life over the patient's limb. So really being careful about this overall approach to the patient, very, very important. I like that a lot. But let's say we have this particular patient, their issue is that they have diabetes, type 2 diabetes, their A1C is not particularly well controlled in spite of everybody's best efforts. And now they have a tender, red, warm, painful leg. It does not seem to be involving hair follicles. It does not seem to be involving the joint. You're able to move the knee, the ankle. This is not looking, for example, like gout. There's no podagra, meaning first metatarsal head involvement, and the patient does not have a personal history of gout. And it's unilateral. So you're thinking cellulitis in this case. I'd love to know what germs you're worried about that might be driving such an infection, please. Erica, thanks. Yes, Staph aureus can do. I think that's a smart thing to keep on the list. Although we are now pretty focused on strep, group A, group C, group B, group G, beta strep, it's possible for Staph aureus to do this as well. And I think that's important to keep in mind. For our patients who have a personal history of staph, whether it's old school MSSA, new school MRSA, if there's a personal history of that, then I always keep that on my list, even in non-purulent cases. Classic examples would be people who are struggling with opiate addiction, people with injection practices, or, of course, people who have been the proverbial medical patient, someone who's in dialysis frequently, someone who's recently come from a skilled nursing facility. Those classic epi-risk factors for Staph aureus, they're real. So Staph aureus can do this, although it is exceptional. We really think this is strep. Typically, if there's no pus, think strep. If there's pus, think staph. Staph loves to make pus. Staph loves to get in through the hair follicles. And remember, even a patient with diabetes who may have a hairless shin, they still have hair follicles where the hair used to be. Those are pores in the skin. Those are portals of entry for the staph to get in. So contiguous spread that way from Staph aureus would be more typical in pus than in non-pus. So if cellulitis is typically caused by beta hemolytic strep, group A, group B, group C, group G strep, how does it get in there? What might give you a clue on your exam? You're looking for excoriations, animal bites, fish hooks. There's your problem. No, you're looking for anything that's obvious that way. How else do we think strep may enter the lower extremity? I mean, the classic thing that we think about, guys, is it contiguous, meaning direct spread, or is it hematogenous? Has it come in from a distant site? In the case of skin and soft tissue, yeah, good idea, Monica. So venous catheters, central or otherwise, in an antecubital fossa, central line, it's possible to get into trouble with bloodstream infections that way, which could settle out in the leg. Typically, this will be direct spread or lymphatic spread. And what I'm asking you guys to do is to look at these patients. The shoe comes off, the sock comes off. You can wear gloves, it's completely fine. But really grab that foot. Spread the toes, fan them out. You're looking for tinea pedis, the macerations, moist areas, fissures between the toes. Many, many Americans have tinea pedis. It's common because we neglect our shoe gear. A lot of these patients are not able to do foot care. They may not have actually touched their foot in quite some time. They can't reach their foot, for example. And in the diabetic patient, there's also the issue of neuropathy as well. So the issues you're looking for in a red leg is to look in the foot because these tend to be ascending infections. If there's tinea pedis, we can treat that. Now, I can't treat fungal nail infections, onychomycosis. That's hard to do, and we do not usually treat with medical therapy for onycho. Although pulse dose ketoconazole is studied, I worry about its hepatotoxicity, drug interactions, etc. But anybody can be treated for tinea pedis with a medicated foot powder, with a foot cream, etc. They came in for a red leg, you're giving them antibiotics, you'll tell me in a minute what you're going to give them. And now I'm telling you to treat their athlete's foot. We do this because we're trying to prevent this from coming back in the future. So think about portals of entry, please, on the foot as well. So that's good. Tell me then, what kind of antibiotic might you select for this patient? What do you think? And by the way, guys, yeah, cephalexin from Aaron. I'm going to share screen here. I think everybody's probably at one with the Occam. Here we go, Google Chrome. Can you guys see my Chrome screen here? These are the questions that you've asked. So for those who haven't yet marked this, either on your phone or here in the library, please add this to your browser. So hsl.uw.edu/toolkit/care provider. This is your clearinghouse for web searches. This is the library at your fingertips. Please spend a little bit of time here seeing all the different resources that are available. But if you scroll down, I'm sorry you have to scroll down. I wish it would be bigger and at the top. But here it is. Occam, OCCAM. That's your online clinical care advisories and messages. And if we click on that, remember, this is the same exact thing that you would get on your phone, all these different applets. The nice thing about the screen here is you can all gather around and look at things together if you're in the workroom. And you can also immediately see very easily the menu of different options that you've got. So the antibiotic reference kit right at the top. These are sorted by popularity. This is one we know you guys use. So if we click on this, it should give us the ability to look at things based on the infection that you suspect. My version on Chrome is looking a little scrunky. I don't know what these empty guys are. It doesn't look like that on my phone. But anyway, here's cellulitis. So if we click on cellulitis, this tells us exactly what Aaron said. Ooh, look at that. Non-purulent or purulent. Holy cow, it's actually organized thoughtfully. So under non-purulent, for the admitted patient, again going after strep mostly, cefazolin. That's the IV flavor of cephalexin, which is the oral form that's here as well. The typical duration of 5 to 7 days. Why do we say 5 to 7? Because, we used to treat longer, and it's not clear that longer courses are better for these patients. So a couple of pearls about the treatment with these antibiotics. Number one, your patient should look worse within the first 24 hours. That's my dramatic pause to let that sink in. I'm going to say it again. Your patient should look worse within the first 24 hours. No one really understands why, but if this is streptococcal, remember, these strep species are always susceptible to beta-lactam antibiotics. Cefazolin or oral cephalexin should nuke them. And when that happens, this great bioburden of strep, they die. They rupture, they belch out their guts. They actually liberate more toxins temporarily. You'll have more exposure temporarily of the insides of these bacteria. That engenders a big inflammatory response. So I just cannot tell you how many times we have struggled with this concept with excellent teams on the wards who said, God, we followed your guidelines, we gave them the cefazolin, now they're looking worse. We're going to go to Vanco or Piptazo or something like this. So I have struggled with what to do with this. I have proposed that we not examine the patient for the first 2 days. That doesn't go over well with the billing and coding people. That doesn't make me popular. So that's fine. Take a look at it. If you choose to ink the margins, that's fine, but expect those margins to be violated. If you take a photograph with your Haiku app on your Epic phone, that's all good too, but expect that it will look worse the next day. That puts you in a tough position because you want patients to get better. I totally get that. If the redness of the leg actually increases appropriately, what you should not see is hypotension. You should not see rising fever. You should not have a patient who's clinically overall getting worse, just a more red extremity. I hope that that's clear, and if there are questions about that one teaching point, I would love to entertain them, of course. Oh, and Linda, thanks for putting in the link there for people to see on chat. That's very nice. Point number 2.
Dr. Pottinger.
Oh, yeah, please.
Sorry to interrupt. I just want to clarify. So you're saying like the area of cellulitis on physical exam will probably look worse in the first 24 hours, but systemic symptoms should be improving.
That's correct.
Fever and stuff. Okay.
The patient may very well still be febrile for a couple of days into an admission for cellulitis. The fever will not just go away like that. The patient should not be septic, but they may say, you know what, doc, your antibiotics are no good. I'm looking more red than I was yesterday. That's actually expected, and I do often coach our patients. I don't coach them, I prepare them for this idea that as the germs die, they're going to be cleaned out by the recycling system of the body, and that this will actually make things temporarily worse. That can help to set expectations so that patients and nurses especially do not become frustrated, confused, or upset with us for doing this.
Thanks. And then is there a pattern for white blood cell count that you expect?
You know, these patients should have leukocytosis. It's not required, but they ought to mount a leukocytosis with the neutrophil predominance. That's what we're looking for. I would not expect the bands to crank up over time. Bandemia should go down, but these patients should have a neutrophil predominant leukocytosis, and that may last for a period of days as the body responds appropriately. And the key here is that even when, getting back to duration, even when the patient's germs are all dead and gone, there will still be pain, there will still be swelling, there may still be tenderness, induration, erythema, warmth. So what we have done over the past decades is to make a mistake with our treatment of these patients, because we've usually treated until people are well. I mean, I know that sounds like the most obvious thing, but it's not correct for most infectious disease. In most infectious disease, the germs will be dead and gone very quickly, but then the inflammatory response, the repair, building of scar, relaxing of inflammation in the lymphatics, whatever it may be, that takes much more time. In the case of cellulitis, again, most is caused by strep infection. You can almost walk into the room and whisper the word penicillin and the strep will die. They're exquisitely susceptible to beta-lactam antibiotics, and yet it does take time for them to ultimately look and feel better. So that's why we usually limit to 5 days. IDSA guidelines says 5 days. I'm giving you the wiggle room up to 7 because, let's face it, it's UW. We're the medical school for 5 states. You get complicated, very comorbid people. I get it. And especially those with reduced circulation, poor lymphovenous return, it may take a little bit longer. But that's what I would set somebody up to expect, that the total course could take about 5 to 7 days. They don't need to stay in the hospital that whole time. You can step down to PO once the patient is looking better. The average time to making that happen is about 48 hours. Most cellulitis can go home on this after 48 to 72 hours. Your results may vary. It just depends on that individual's personal situation, etc. What else can we do to help them accelerate their healing process, please? We talked about treating athlete's foot. That's for next time. What else can we do this time to get things better? I think this is actually one of the questions that we had, a really wonderful question here. Love it. There it is. Steroids. What are the hot takes with steroids? I've seen them work really well, but once, but get a little gun shine in patients with comorbidities. How long? Those original papers had 10 days, but the antibiotic duration was long then as well. So I thought this is a very topical question regarding steroids. So corticosteroids have been proven in clinical trials to accelerate the time to discharge because patients look and feel better faster. These were European trials with a really sort of crazy, I don't say crazy, in my opinion, overly complex and needlessly complex dosing schedule for their prednisone. But what I do for these patients is I'm a very avid believer in and user of corticosteroids if we do it thoughtfully. Number one, it should be classical cellulitis without pus, without high concern for Staph aureus. The European experience in those trials was strep, and that's what I'm looking for in my patients. Number two, I really usually do not do this in patients who are struggling with diabetes. As you guys know so well, when we dose diabetic patients with corticosteroids, glycemic control becomes really tough, and glycemic control is very important. So for patients with anything other than totally well-controlled diabetes, I just would not do it in diabetic patients. I say that with heavy heart because it really is beneficial not only to send patients out quickly, but also to reduce their incidence of recurrence. This cellulitis sucks. They're on your service. Nice person. You wish you could send them home. That's bad. What's really bad is the readmission and the readmission and the readmission again. And with every one of those episodes of cellulitis, there's so much inflammatory damage to the lymphatic return that those lymphatic channels will not fully reconstitute themselves. You'll get more lymphedema, and where there's lymphedema, there's strep. We're covered in strep. It's everywhere. If you have athlete's foot, it gets in through the toes. Now there's this great pool of nutritive lymphatic fluid. You get more and more cellulitis. So the benefit of prednisone is not only to get them off your service today, but it's to pay it forward to your friends, your classmates, not to readmit that person again. So reasons not to do it would be would be staph. I only want to do it with strep. And another reason not to do it would be with patients with uncontrolled diabetes or anything other than very tightly controlled diabetes. And finally, I do not use this long, strange, painful 10-day thing. So I give them prednisone, 60 milligrams once a day, and I'll do that for usually 3 or 4 days. A short course with no taper. Now, if your patient is already on mineralocorticoids, there may be reasons you'd be worried about their cortisol balance, and maybe you'd have to do a long taper in somebody's case. But generally speaking, for people who are not otherwise on prednisone, I blast them for just 3 days and then I stop. And that's different from the way these trials were done, and I'm fine with that. I think it was needlessly complex and fraught the way that they'd done that before. The other question that came up around cellulitis was about dosing. I think I have that in here. Where was it here? Somebody was asking, can we please do it less often than every 6 hours? Which I thought was great. I think I'm missing it here, but I know I saw that question here somewhere. So for cephalexin, the dose, does it really have to be Q6? For an acute case of cellulitis, for somebody with normal kidney function, it really should be 500 Q6 of cephalexin. You will have patients who will not be able to do that. Most of them are dudes. I am one of those dudes. We just suck at taking medicine. So be honest about this. I usually coach my patients to say, I want this to be every 6 hours, or at least 4 times a day, if not literally Q6. But the reality is that if you do these other things to set up your patient for success, doing it 3 times a day is probably okay in most cases of this infection. But for larger patients who are struggling with obesity, with very large BMI, I really do worry that every 8 hours is not enough, unfortunately, for cephalexin. These are beta-lactam antibiotics. They are time-dependent killers. The more time we spend above that level of the MIC, then the greater benefit we're going to get. And for the bigger volume of distribution, it becomes a problem. So it really should be that. But focus on a short course. It's going to be a painful thing. It's going to be every 6 hours, but it's only for 5 days, and then you should be good. Folks, the other thing to set them up for success is elevation. I know it's very medieval, feels old school, literally old school, but I do ask our students on the service. I put my students when I attend on medicine, they're in charge of the pillows. At UW, the pillows we use are very, they're not very plush, so it takes about 5 pillows to elevate the foot. The foot should be higher than the heart. That's if somebody will say, like, oh, I'm watching The Price is Right and I've got my foot up on the Barca lounger. That does not do it. I want that foot higher than the heart, having gravity to accelerate lymphatic return. That I have not seen put head-to-head with corticosteroids. My opinion is it's probably the same, and yet we don't often do it very carefully. I don't want the patient to be bedbound. I don't want them to catch a DVT. They can get up and walk around, but when they're at rest, they really need to make it up and up high. So those are the things that come to mind for me with non-purulent cellulitis. Any other questions about that? Oh, there was a nice question here from Nick as well. What happened to people before antibiotics? Would anyone who got cellulitis just get sepsis and die? Seems like a lot of people would have died this way. Yeah, no, you're right, Nick. We think that from the pre-antibiotic era, we do have medical records. It's only been for 100 years we've had antibiotics, so most people would survive cellulitis. How would they do that? Elevation, rest, and time. But this can, of course, be a source of not only sepsis, but terrible disability in people who would get a really inflamed, chronic, dysfunctional leg. So the antibiotics have been a miracle, and the treatment medically with cellulitis is appropriate. Thank goodness not everybody died this way, although there are some very real, celebrated cases where people would end up with death this way. That was usually from necrotizing fasciitis. So I won't spend too much time on neck fasc because it is a surgical emergency, and it's a surgical case. My question for you, my friends, when you're admitting a patient with cellulitis, how do you decide whether that patient has neck fash or not? If they do, they need to go to the operating room, right? But they're not going to be admitted to surgery. They'll be admitted to you. Things that you're looking for, please, with respect to making that determination. And Hannah, thanks for reminding me about this. There's an elevation order in there. Yeah, Ala is correct. Crepitation. If you feel Rice Krispies under the skin, this implies subcutaneous air. That's not good, and that could imply the possibility, in particular, of a type 1 necrotizing fasciitis, sometimes called Fournier's gangrene, or type 1 neck fash, or type 3, which is the gas gangrene due to Clostridium perfringens and other organisms. So that would be a non-starter. That patient should go to surgery. And remember, a plain film will usually reveal in beautiful anatomic detail the striations of the muscle. You can see the muscles because there's air around them just on a plain film. I think other things you're looking for, believe it or not, would be lack of pain. A patient who has a bad looking limb but it doesn't hurt them, it's because the nerve endings have been killed off. They've been necrotized. And of course a patient who's becoming septic. These are big issues. In the case of Fournier's type 1 neck fash, we're also looking for that anatomic location in the perineum. These are cases of perineal cellulitis. Fournier was a French physician. My friend Hunter Wessels, who runs urology, has translated from the original medieval French these descriptions because he's a Francophile. He loves all things French. And it's interesting, that experience in the original case series is the same as our experience today. That these are actually infections that arise from the ischiorectal fossa. These are colorectal infections that then move forward towards, it is usually men and with the scrotum, but the vulva can be involved in women as well. Women can get neck fash, it's just less common. So that's when patients leave the operating room with neck fash, there will always be a Penrose coming out of the ischiorectal fossa. You've got to go deep. That's the proverbial lava dome to our allegorical volcano that we're looking at. These are not just skin and soft tissue. These are surgical emergencies. Those cases should be done within an hour, and all the dead tissue should be on the floor very quickly. And those patients may survive and do very well indeed, unless they're not operated upon. So for those of you, all of you here today are internists like me, you should have a very productive collegial relationship with your friends in surgery. So if you have these concerns, call your friends in surgery and say, hey, I'd like an urgent consult. I am concerned for neck fash. They get these questions all the time. The emergency room pings them all the time. They may be overworked. They may be less well supported than you are in your medicine residency program. They may be grumpy. Doesn't matter. Meet them at the bedside, examine them side by side, and have that communication. If you only call for cases where there is neck fash, you're probably not calling enough. And just as the surgeon should operate and have false negatives, I should say, for appendicitis, so too for neck fash. Call them. Don't be embarrassed. Don't be upset. If it's 3 a.m, the patient does need to be seen. And if you ever have issues with someone who's not willing or able to come make that assessment, just let me know. It means there's a systems issue that we can work on. And just as we've talked about for cellulitis, that's cefazolin or cephalexin. In neck fash, depends what kind we're talking about, right? So we do have different flavors of necrotizing fasciitis. Let's go back here for a second. Neck to the fash. Here it is. Notice that there's a scalpel. That's our icon for neck fash. So for NSTI, we usually will give these patients vancomycin to go after all things gram-positive, penicillin to go after all of the strep that's there, and then Clinda and Levo. Clinda is there to block toxin production. It is a ribosomal active antibiotic, and toxin production is one of the hallmarks of NSTI. The levofloxacin to get more gram-negative coverage, including most community-acquired Pseudomonas. For patients who have Fournier's, as you can see here, or people who are neutropenic, we would actually replace Pen and Levo with just Pip-Tazo. It's one of the few times we do endorse the use of Pip-Tazo for these patients. What's key, though, of course, is that they need to be debrided, and then the course of antibiotics can be short. Any questions about this, please? I think there might have been an NSTI question here. Let's see. Okay. So let's change over to purulent, and then we'll talk about bone, if that's okay. So for purulent infections, again, where there's pus, does everybody feel okay about draining those? You'll do this actually less on the wards and more in urgent care and in your primary care, where patients will come to see you with a purulent infection. The trick with purulent infections is, of course, these are typically Staph aureus, either MSSA or MRSA, and you just want to get the pus out. This is important. We as internists tend to do less of a thorough clean out than our colleagues in surgery. If you envision yourself doing quite a bit of urgent care work, see if we can set up a way. Oh, Tess, I don't know how we would do this. It might be great to have someone spend a day with a surgeon and just up their game regarding their IND skills. That could be done in the emergency department, even better. The trick is that it's perfectly fine to anesthetize that patient, but we really do want to incise. Scalpels come in two flavors, the pointy and the curved, right? Pointy scalpels are for stabbing, curved scalpels are for drawing towards yourself. So for this, you'd probably want a pointy one. You can prep the skin if you want, but it's full of infection. I don't actually care that you prep it. I don't usually do that, but just numb it up and then stab it and spend a little time getting that pus out of there. To pack or not to pack, that question comes up quite a bit. I think it's judgment call. Typically, I do like the idea of packing, even if it's only for the first few days. And through our emergency department, for example, we do have a wound care process where those people can come back to the ER and be checked for a wound care check and repacking once a day for the first few days until the packing can finally just come out. We're trying to prevent this cavity that we've created from sealing off at the top, right? We want it to granulate in by second intention from the bottom. If we do this, then antibiotics are usually not indicated. Now we have two very important, I think really good, well done, important papers that were published several years ago showing that patients with purulent skin and soft tissue infection who got IND alone versus IND plus empirical antibiotics, there's about a 10% better outcome for those who got antibiotics, usually trimethoprim sulfa, because it's so much MRSA infection. And so, we've gone back and forth about this. I still usually do not give antibiotics in those circumstances because the patients who I see are older, they're on warfarin, they've got congestive heart failure, they may already be on a thiazide-containing diuretic regimen. Playing with their potassium level is not necessarily so easy. In the younger population, I think it's sort of an easier thing to do. But it is still controversial, and even though there's about a 10% improved outcomes, meaning less likely to need a second IND, for those who get trimsulfa or doxycycline, I still don't usually recommend this. But if you do reach for something in those cases, doxy is probably a great way to go. Doesn't mess with your kidneys, your creatinine's not going to look scary, and as long as people can take it with food and not get a bad sunburn, it's a pretty benign way to go. So that's an option for you. If you are looking at a patient, you do the IND, and they still have a pretty substantial surrounding erythema, that's where antibiotics are indicated. Even if it's not quite the proverbial 5 centimeters across, don't feel guilty about giving them some doxy just for a few days. That's probably quite appropriate in those cases. Any questions or war stories or pearls about purulent infections? Okay, well, let's talk finally about the diabetic foot, because this gets us into the question of bone infection. To me, the diabetic foot infection is one of the most vexing. It's so painful in every way for everybody. And this is why Chloe Bryson Kahn and one of her colleagues in general surgery have put together this applet within Occam. I just love it. Please spend time looking at it. It's really, really helpful. And it's true whether you're practicing inpatient at Harborview or inpatient at UW, or even in your clinic. Let's walk through it together, please. I want to familiarize you with this. So the first thing that we ask is that people categorize the infection. Is it infected at all? And if so, how severe? And so, yep, there's a scoring system for that. No surprise, IDSA has come up with this. You need, for mild infection, to have at least 2 of these relatively common sense, straightforward things, exactly what you were asking about when you mentioned your assessment for the patient initially. And that you're trying to exclude other possibilities. Gout is there, Charcot's arthropathy, some of these things that can be tough, frankly, tough to do right at the bedside. You may still have some diagnostic uncertainty, but what you will not be uncertain about is moderate or severe infection, because you're looking for these things all at the same time. So making that bedside assessment to categorize the severity of the infection, the first step. This is for diabetic foot. right? It is not built for animal bite or man versus chainsaw or somebody who had stepped on a fish hook in the water. This is really for diabetic foot. There are core principles here that really do work well for decubitus ulcers as well. And frankly, you're going to be seeing, unfortunately, quite a bit of those as you admit patients from skilled nursing facilities, etc. So some of those core concepts are the same, assuming that we're talking about contiguous chronic wound with potential for contiguous infection, not bloodstream infection. So the initial assessment, number one, clean the wound. Just looking at a smelly wound coming off the street, coming out of a sniff, not good enough. The nurses are trained to clean this with soap and water. Nothing fancy, but you really do want that area to be cleaned because otherwise you don't know what you're looking at, foreign material, etc. Cleaning with soap and water is not wrong. In fact, it's essential, and it gives you as a physician the ability to make a more accurate assessment of what you see. And sometimes it's frustrating for the nurses because they clean it, then they dress it, and you walk in inevitably 30 seconds later and undress the wound. It drives the nurses crazy. So just be kind to them, coordinate with them, tell them, please don't dress it, just page me, and we'll do an exam together, a shared exam. I think it's very beneficial. I always learn from our nursing colleagues when I examine wounds. They're so good about all this. It's going to be very helpful. Simple labs are reasonable, and in the case of the diabetic foot, we do suggest an assessment for vascular competency with an ankle or toe brachial index. And then getting a plain film is usually very helpful as well. Why? Because of the concern for osteomyelitis, which we'll come to again here in just a moment. Then you'll probe to see if you can probe to bone and get a consult from the wound care team. They're not necessarily there 7 days a week, but it's very helpful to do. We should not neglect talking with our friends from nursing about wound care. They can be really, really helpful to us. Now, probing the wound. How do we do that? Not a trick question. How should wounds be probed? Looking to see if any of my former students or anybody that I've taught this is here on the call. I don't think so. Because the nurse has a Q-tip. They're going to hand you an applicator Q-tip. That's what you're given. But you're not going to use that. So that's the trick, is that if you cannot see bone, but you're wondering if it may be involved, please do not use plastic or wood or cotton because that's too squishy. You want metal, and it can be a metal Metzenbauer pair of scissors. It should be blunt, not sharp, but get some kind of steel instrument from the sterile supply. Why? There are vibration sensors in your pads of your fingertips that will appreciate that transmitted through the metal. Imagine that you took a metal probe and scraped it on granite. Okay, you would feel that instantly, right? That's what you're looking for in this case. There's nothing like that, the feeling of bone on metal to your fingertips. So that's how we propose that you do this. With that in mind, let's talk about it. So what are we looking at? Number one, there may not be any indication for infection, in which case don't give them antibiotics. They've got a wound, it needs to be dealt with. We will refer them to wound care, but no need for antibiotics, please. Number two, for mild infection, and again, going back to our criteria, they've got two of these findings, but they do not have sepsis. They do not have findings for moderate or severe infection. So for mild infection, it's usually gram-positives that are there. Typically, we do not need to culture these. One of the nice questions in the chat or the forum was, when do I culture a wound? Usually we try not to do it. You know of three things in life: death, taxes, and a positive wound culture. Oh, and a positive urine culture. The four things of certainty in life on planet Earth. So we try not to. Usually, if it's mild infection, we'll just treat empirically. Why? Because this is typically going to be staph and strep. You can see the suggestions that we have here. You're trying to do no harm, and you may be able to calm down surrounding cellulitis. If this is osteomyelitis, this will not do. This will not do. This is only for patients with a chronic wound. Doc, I think it got worse. It started to smell bad. It got more red. Believe me, this is a change. In that case, give them a short course of antibiotics like any other skin and soft tissue. But it's only really for moderate foot infections and beyond where we really feel like cultures can be helpful, but not a swab of the wound again. We're looking for deeper cultures to decide, is it Pseudomonas or not? Is it MRSA or not? These tend to be mixed infections, and so your coverage will be broad. That's appropriate. But those main branch points, MRSA or not, Pseudomonas or not, that's helpful to do. The way to do this is with a true deep bedside culture. We have at Harborview a wound care nurse practitioner who can do this for soft tissue purposes. They can actually go in with a pair of forceps and go into the wound and grab a hunk of meat from the patient's wound and send that off, not on the surface, but deep. On the other hand, if it's bone, as we'll talk about, you really do need to have help from either interventional radiology or a surgeon to guide that process. We'll talk about osteomyelitis again in a moment. So again, if your patient, I'm going to highlight this, if your patient is clinically stable, they came in with DKA, they came in with an MI, failure to thrive, and they also happen to have a wound, please, if possible, do not give antibiotics. We would much rather get cultures to guide us and then focus on this in an organized way, which will be mostly outpatient in particular. But once you have cultures, then you can start your patients on antibiotics, and we like PO. These are chronic wounds. These patients are not being admitted necessarily because their wound is blowing up. That's a different scenario. But in most cases, you can give amoxiclav and doxy. This is going to get the strep. This is going to get MRSA. This is going to get MSSA. This will get most of the anaerobes that are giving it a malodorous presentation to the wound. On the other hand, if you think that it's in the bone, we would usually then go to parenteral antibiotics. In ceftriaxone, metro, look guys, that's the way we would treat an acute abdomen, right? We're trying to get all the Enterobacteriaceae, the strep, the MSSA, and the anaerobes. And we would only cover for MRSA if the patient has epidemiological risk factors or if there's pus. Not fibrinous exudate, but pus. True pus, I'm thinking MRSA every single time. And then, based on your cultures, you can focus and de-escalate. Now, we do have a list here of people to talk with. Every hospital is different. I am so sorry about that, but if you come back to this each time, you'll remember which consults are appropriate. So the wound care team at Harborview is a PROPS. They may send that person to podiatry, either for amputation or for further management. At Montlake, we just should not treat these patients inpatient. We have a wonderful team at the Northwest campus. You guys may know that UW Medical Center has 2 campuses. It's sort of a weird thing, but Montlake just does not have podiatry and wound care, whereas Northwest really does. So that's when we typically call the transfer center and say, hey, can we please send this person up for a higher level of care? At Northwest, they consult podiatry, etc. ID can always be called. We're happy to do this, especially if the patient's complicated, the bugs don't seem to be responding, etc. We are always happy to be involved, of course. And remember that ABI, if that looks bad, vascular needs to come in. Very multidisciplinary approach. You are eager to send people out of the hospital. So we have this checklist that Chloe and colleagues have put together, putting our best foot forward. So these are the things that you should think about if you're going to discharge somebody with a diabetic foot ulcer. It's hot linked right there in the guidance. And so these are the things that if we do these, the best of our ability, the chance of that person bouncing back and getting readmitted will be substantially reduced. And finally, for osteomyelitis. So the things that we're thinking about for osteo, please get a film. If you see erosions of the bone without another explanation, that's osteo until proven otherwise. If you can see and touch the bone, that by definition is probably osteo. I say probably because it is possible for someone to have an exposed bone that is not infected. The bone has a wrapper, it's called periosteum, and it does a wonderful job repelling invasion of germs. But generally speaking, if you can see the bone, grab it with your hands, it's probably infected bone, and we will probably treat them in that situation. Those patients tend to have very high inflammatory markers. That's nonspecific, but it's something that we often look for. The bigger the ulcer, the greater the chance of contiguous osteo as well. And if you actually treat them for soft tissue infection, you actually do offload them, which is essential here, and they don't get better. The source may still be the bone. It needs to be operated on. That was one of the questions that we had. I liked a lot. When do we operate on bone infections and when do we not? If the bone is dead, it should be operated on. A dead bone is called a sequestrum, and it needs to be removed. If we don't, it'll just keep coming back. You can mop up the surrounding infection, but at the center of infection will serve as a keep reemerging. And so generally speaking, especially in the diabetic foot, we really do need help from our limb salvage team, etc. Very, very important here. So these are the main things that we're thinking about with osteo, and these are the people that we would like you to call if you're seeing these issues, thinking about osteomyelitis. So with osteo, to summarize, microbiology is very helpful. It is rarely an emergency. These will be long courses of treatment with antibiotics, so we would love to know what we're treating, and they will almost always involve surgery. If it's in the spine, that's a spine surgeon. If it's in the extremity, it'll be with podiatry, orthopedics, or general surgery. So getting your colleagues from ID and surgery on board in cases of osteo is very appropriate. That's what we do in our clinic. We take these patients from inpatient, transition them to outpatient really work with them over a period of weeks and sometimes longer, long courses of antibiotics. In general, for ID, shorter is better, but in bone infections, we do tend to go longer. And so if we have a diagnosis with microbiology, that really helps us out quite a bit. Okay, I'm going back, since we're almost out of time, going back here to see what I missed. Was it reasonable to treat with antibiotics versus surgery? Source control, source control. You need to have that source control with surgery for sure. We talked about steroids, swabbing the wound, how to decide. In general, you should never swab the wound, but if you think that the patient needs microbiology from their wound, work with the wound care nurse or surgery to get a deep specimen. It's a little bit perilous for you to do that as a superficial swab. We talked about this. QID meds. I knew it was in there. Excellent. We talked about QID meds. It's painful. I get it. If you knew that it was strep, you could give penicillin, which is even harder to dose, or augmentin, amox to the clav. That's Q12. You may not know whether it's MSSA or strep without a culture, in which case I really do like cephalexin for that purpose if they can. Major factors to determine when flora or colonization will result in an infection. How do you prevent cellulitis? Foot care, foot care, foot care. Treat the tinea pedis. Have people invest in a new pair of shoes every couple of years, or when they start to smell funky, you probably need to be in new shoes. So diabetic care, skin care, foot care. We talked about keeping the fungus away. By the way, so many patients have a dry skin, a lizard-like elephantine skin. They just don't moisturize. And I don't care what they use. Dermatology loves Vaseline. That's fine. It's a little greasy. I like CeraVe, the ceramide vehicle, or whatever things that people want. Lubriderm from the tub. But after they bathe, they should pat their skin dry and then immediately moisturize. Without that, you get the craqueole appearance of the skin, invasion of strep. So I think that's an important way to help prevent cellulitis. And we talked about the bad old days of the pre-antibiotic era. Hey, let's never go back to that again. Thanks for your wise use of antibiotics. Tess, are there other questions? I can go to the chat and see what else might be there.
Yeah, we have one. Let's see.
For patients recovering from osteo who have chronic changes on imaging, how do you recommend assessing the possible infection status of their ulcers in their bones? Yeah, I mean, I have this vision I'm giving you, which is that in chronic osteo there will be surgery to clean out the dead bone. The reality is that not all osteo needs to be operated upon. There's degrees of severity. But to be clear, for patients where you're doing the medical treatment of osteomyelitis, those plain film changes will never go away. It's very, very slow for them to remodel in a way that you would pick up on a plain film. So unfortunately, plain film monitoring will tell you if things are getting worse, and they probably are, but they will not tell you if things are getting better. It's a similar story with MRI or nuclear scans. These tests, MRI in particular, incredibly sensitive. They're too damn sensitive, and they will be abnormal in cases of osteo, absolutely. Number one, specificity is not there. Charcot, osteo, they look pretty much alike on MRI. And then number two, they will get better in a very delayed fashion. So you will end up in a situation where you treat empirically for a long course of antibiotics, hopefully guided by culture, and you're going to go that based on the calendar and treat these patients for a period of weeks. The duration is what we'll work with you on. If it's hardware-associated spinal infection, that's 12 weeks. Right? If it's somebody who had a toe amputated and it looked a little manky at the margin, you could probably just go for 1 week. It just depends on the source control. If your source is controlled, you can go for short courses. Without source control, they tend to be very long courses indeed. Good question. Let's see how we're doing here, Tess.
I don't see any new questions in the chat. I think you've answered all of them.
Well, others will come up. So one thing you can do is consult ID. We're always happy to talk with you about this. We're in the process of building new guidance within Occam for osteo. We've just touched on osteo a little bit. It remains very confusing. It's a very diverse, problematic thing. A prosthetic joint is different from a septic joint, which is different from brucella in the spine. So it's a huge part of what we do in our practice. Nevertheless, we're trying to give some general guidance within Occam that'll give you more information. That'll also give you more consistent information from ID. We're trying to be more consistent with what we tell you guys. So keep a lookout for that. New apps coming in the next few months to Occam. But if you do have other questions, you're welcome to reach out. Looks like one just popped up here. What's resistance like for staph and strep in penicillin? Thank you so much. So there has never been, and there never will be, a penicillin-resistant Group A strep in the Northwest or anywhere on planet Earth. Group A strep has never been reported to be resistant to penicillin. I can't tell you why. It just is not happy to change its PBPs. It does not like to make a thicker cell wall. So the drug of choice for Group A strep, Group C, Group G remains penicillin, or cefazolin, cephalexin by extension. Staph aureus is different. In Staph aureus, remember MRSA is totally resistant, but MSSA here in the Pacific Northwest, yeah, approximately 5%, about 1 in 20 MSSA are actually fully penicillin susceptible, in which case you can use it. There's suggestions in some trials that pen for pen susceptible infections works quite well indeed. The lab rarely tests for this. They do it only on our request because it's a bespoke art where people have to look at beaches and cliffs on the plates. Rotate with us on ID, we'll show it to you. But generally speaking, for MSSA, we're doing beta-lactams, and the proportion among all staff that's MRSA versus MISA depends on the hospital. Harborview, it's half and half. At my hospital, UW Montlake, it's about 2/3 MSSA, 1/3 MRSA. Plenty of MRSA here, plenty of community-acquired MRSA here. If you're thinking a staphylococcal infection, treat for MRSA. This is really important. Good questions. Okay, I'm always happy to do this. Yeah, please do. Thanks, Tess, for asking for feedback. This is helpful because this is a very weird lecture. There's no slides. Some people hate that, so give that feedback if you want me to change. I won't, but you can give that feedback. That's fine. And then thanks for that, too, so we can see what other topics are helpful moving forward as well. Within the curriculum for ID, I think we have 6 sessions that we do during the year. Pneumonia, we talk about endocarditis. There will be STI lecture. I forget what else we've got coming up. But anyway, there's a variety of these talks. We're always happy to do them. Viral hepatitis will be one. That's super fun with Maria Corcoran. Glad to do this with you. Thanks for your time, guys. And go out, have fun on the wards. Welcome to Seattle. I promise it will cool off. And thanks for being great doctors.
Dr. Pottinger, thank you so much. I'm going to just share my screen with a QR code for people who are maybe joining as a group. And
Let me stop here. Hold on, I can do that. Thanks, Tess.
Absolutely.
Oh yeah. So for Sam, what's the code? So you have to be. So Sam, if you're a UW person, that's your code. It's your email. It's your email identity and then your email password. That's your UW identity. I don't think you can do it with your Epic login. I think it's supposed to be by your identity by your email. It should be the same thing.
Are you looking for a code for the survey or?
You said here UW ID reference kit. Oh, sorry. I beg your pardon. You're looking for the ID reference kit. Yeah, the ID reference kit, that's built for ID only. So that is not open to you. For you guys, it's the antibiotic reference kit. The ID reference kit contains all kinds of internal stuff, people's home phone numbers. That's procedural for us. So you're right, Sam. Sorry, that one is not for public consumption. But rotate with us on ID. I'll give you a glimpse. There's some good stuff in there. Most of what you would need for your practice does not live there. It's more logistical, put it that way. Yeah, and sorry, you're no worries. And Ruth, sorry that you can't do stuff at the VA. I know, it's just...
Can you see the QR code that I'm sharing? Is it sharing? Maybe.
It is being shared, Tess.
Okay, great. Okay. Ruth and Deli. Yes.
It's too low res for it to work. Oh, that is...
We will try to get
sad,
you a link.
Man, it's so sad. Okay, thank you guys so much. I got to go to clinic. Good to talk to you.
Thank you, guys.
Cheers.